I'm going to talk about classification and management, focusing on management principles. So these are the areas that I'm going to cover about, looking at the epidemiology, relevant surgical anatomy, specifically the vascularity, classification, management, and a brief overview on complications and how to get your principles right. They're relatively rare injuries, less than 1% of all pediatric fractures, and those of you who have an adult practice, you'll see, if you look at fracture neck of femur as a large population, even amongst, compared to adults, it's a very rare fracture. Most of the time, they're associated with high energy trauma, and that's something that you need to remember. 85%, they don't happen just like that, unlike in the adult case. So you can end up having problems, you may end up missing them. There is a greater potential for having complications and poor outcomes with this. So this is a picture that you need to kind of remember, that the medial circumflex artery is the main supply for the femoral capital epiphysis through its postero-superior and postero-inferior branch. So you need to be aware of the changes in blood supply which happen as the child grows. The physis is a watershed line, and only after the physis closes that the metaphyseal vessels can go in, but up until then the physis is a watershed line. Ligamentum teres supplies only for a very few years, very tenuous blood supply. So if you have fractures at these two levels, you can understand the implication. If it's closer to the physis, right at the transphyseal level, it pretty much disrupts all the blood vessels, and therefore you can almost immediately extrapolate that the complication rate of AVN is going to be much higher, whereas a basicervical fracture may spare some of the vessels, and proportionately as you go away from the physis, the incidence of AVN decreases. So these are the reasons why you have higher AVN. In addition to that, if you have a hematoma, intracapsular hematoma, that produces a tamponade effect on these very fragile retinacular vessels. So this classification, unlike the variations, Delbert, if I'm not mistaken, the Delbert classification is one of the oldest classifications which have stood the test of time. Nobody's tried revising it and bringing in variations. So this is quite simple. Transphyseal at the capital epiphysis level, transcervical, basicervical or cervicotrochanteric, and you have the intertrochanteric. These are the four types. The relevance of it is that, as I mentioned, if it is through the physis, a higher chance of AVN. Fortunately, it's very rare. There are two types, type 1A and B, when it's associated with a dislocation. You need to be careful. Sometimes in a post-septic situation, you may see a malalignment there, which is usually not a traumatic thing, it's a post-septic slip. And those of you who are not familiar with dealing with this entity, you may see radiologists reporting this as a fracture. This is not a fracture. So don't treat it like a fracture with acute manipulation and correction. This is a slip capital femoral epiphysis. Pathology happens through the physis, but this is not a traumatic event. Transcervical is the most common. It's slightly older children. Again, a high energy trauma, and the complications are directly linked to the degree of displacement. The AVN rates are lesser as you go further down. Cervicotrochanteric or basicervical is the next most common. Again, older children. As we go further down, AVN rate is lesser, but then you start having problems related to malunion, coxavara and other deformities. Further down, AVN rate is much lesser, the best prognosis amongst all the four times, and usually complications are related to malunion. So management, the investigations are fairly straightforward. You don't need any fancy investigations. You need a good X-ray, an AP X-ray. Make sure that you get an X-ray which includes the opposite hip as well, with the leg slightly internally rotated. Occasionally, you may need specialized investigations where you think the history does not match with the trauma, and so you see a low energy trauma where you think there is an occult fracture or an incomplete fracture. Those are the situations where you need additional imaging. So in terms of, before you manage them, you need to know what are the factors which can have an impact on your outcome and what are the factors amongst those which you can control. So patient factors you really can't control, but they have an important impact on your outcome. Prognosis depends on the age. The complication rates of AVN are higher in the older children. So your surgical technique is going to vary. The smaller child, you may not be able to put bigger implants. You may have to use pins. You may have to supplement with spica. And so those are the things. So that's not under your control. Injury factors, again, are not under your control, but the three key things, there are a few series of articles which I'll just kind of put up as well, which kind of highlight the factors which have a bearing on your outcome, specifically avascular necrosis, which is the most dreaded complication. The fracture type, I alluded to that. The more proximal to the physis, higher rate of AVN. Time to intervene sometimes may not be under your control. If they're presenting 48 hours later, then it's irrelevant. But if they're presenting fresh, early intervention helps. Initial displacement is a big factor. But again, not under your control. Surgeon factors are under your control in terms of what you use, what technique you use, how accurately do you achieve reduction. Those are under your control. And specifically, time to intervention, again, I'm talking to only as a fresh injury. There is no clear evidence, but convention, again, extrapolating from adult practice, is that early intervention and decompressing the tamponade effect helps. Most often the delay, again, even if it presents to you, is not because you are not intervening, but there are other more serious, these are high energy injuries. So you will have head injury, abdominal injury, and other things which may force your hand and may delay your intervention. In terms of reduction, this is critical. How you choose to do it, whether you choose to do it on a radiolucent table or a fracture table, is dependent on you. Most of the time we end up doing it on a radiolucent table because you don't get the appropriate sizes. Do not hesitate to open the fracture site and get an accurate reduction, because that's a key thing. Don't accept a substandard reduction. You may have to use adjuncts to relieve the tamponade. Even if you achieve a close reduction, just a small nick to decompress the hematoma. As anatomic as possible in the types 1, 2, and 3. Okay, very little acceptable criteria in terms of very little malalignment that you can accept, very little translation and very little angulation. In terms of fixation, stable fixation is critical rather than physeal sparing fixation. So do not hesitate to go across the physis. In cervicotrochanteric and intertrochanteric fractures, you need to kind of use a side plate. Smooth pins are limited to only in small children, and often almost inevitably, you'll need to supplement it with a spica. So this is again from a JOS article. It's been there for almost a decade plus. So in the smaller children, types 1, 2, and 3, you want to use smooth wires. You don't want to use, the screw size is too big for the size of the femoral neck. Whereas in the older children, you can use in the types 1, 2, and some of the 3s, not all 3s, you can use cannulated screws, but you may need in some of the cervicotrochanteric fractures, side plate construct. Almost all type 4 fractures, you need a side plate. You can't rely on just fixation, with just screw fixation. In the smaller children, spica supplementation. Do not forget that. Do not rely on. They're not going to be compliant. Your hold is not very good. So therefore, you really need to supplement it with spica. Complications, these are the complications. Avascular necrosis is dreaded. Coxa due to a combination of reasons. It could be malunion, it could be due to proximal femoral growth arrest. If there is a growth arrest, that can produce secondary leg length discrepancy depending on the age of the child. Non-unions, infection and chondrolysis. So there are a few articles here which have looked at various risk factors and tried to predict what are the factors that you can control. And distilling through those articles, the risk factors which kind of have a direct link to avascular necrosis, the degree of displacement, which is not under your control, fracture type, age, and delay in intervention. So that's the key thing. So avascular necrosis, try and to minimize that, you want to kind of intervene early. The Radcliffe types haven't changed much. They don't really have a bearing on how you manage it, avascular necrosis, then depending on how it presents and what are the symptoms, you will deal with it later. You need to follow them up. It will take about at least 6-12 months before this thing. So don't be happy with your initial fixation and say that everything has gone off well. So before I the last couple of minutes, I'll just take on a few summary points which I think you should remember. These are the common errors that we see in practice. They get missed because of distracting injuries, because there are other more serious injuries in multi-system trauma. And sometimes a lot of the time, the child presents with thigh and knee pain, and the fracture hip gets missed. This happened in my own hospital. This was came with a child with a low energy trauma and X-ray knee, and was sent home as a soft tissue injury. Presented 6 weeks later with this. Mistaken diagnosis. Okay, so when they are referred as a displaced fracture with relatively innocuous trauma, okay, you need to be very careful because a lot of the time, most of the time, it's a high energy trauma. So this was, again, treated as a traumatic fracture neck of femur, conservatively managed. 3 weeks down the line, this is what the situation is. Total resorption of the neck in 3 weeks. That doesn't happen in a trauma situation. So always think pathological fracture in any of these situations. Low energy trauma is pathological unless proven otherwise. Whether it's metabolic disease, a systemic disease, or whether it's a local lesion, that depends on what you find. Conservative management has very little role unless it's truly undisplaced. Okay, like in this particular instance, you can, but watch them closely to pick up any late displacement. Sometimes you have these insufficiency fractures which are managed conservatively because metabolically and medically they're not fit for surgery. They end up this. At the first available opportunity, you need to treat them with operative treatment. They are not going to kind of heal up. Myths. Anatomic reduction is more important. Don't dread open reduction. Get your reduction as anatomic as possible, whether closed or open. Do not hesitate to open it, whether it's through an anterior approach or an anterolateral approach. Fear of the physis. Stable fixation is more important than protecting the physis. All complications, most complications are related to unstable fixation rather than attempts to kind of preserve the physis. Inadequate reduction and inadequate fixation are most often what we see. You see in a case yesterday where it's inadequate reduce, inadequate fixation. So this is an illustration of a fracture which is relatively well fixed. An identical level fracture, you can see where it's not identical level fracture, slightly older child, not fixed well. You know, your reduction is not good, and clearly you can predict the natural course. It's just a matter of time how bad it's going to be. Favorable measures, I talked about capsular decompression and early intervention. Biomechanics get it right. The Rishikesh resident, I liked her presentation quite well because mechanical stability is the key, even in late presenting. Biological adjuncts are not a substitute for poor stability. So when they have late presenting fractures like this, you have a lot of issues, which was alluded to by her in her presentation. Make sure that you get your mechanics right. You know, that's more important than fibula. There may be certain instances where you want to supplement it with the fibula. So you don't need fibula all the time, and that's not a substitute for compromised biomechanics. Fibula stud grafting as needed. Supplemental spica, do not forget, in smaller children especially, where you may need an adjunct valgus osteotomy. Last slide. The story doesn't end with surgery. Follow them up. Radiological union you need to, before you start weight bearing them. Activities, delay them. Follow up until skeletal maturity. Remove the implants because they are right next to the hip joint. Thank you.